Hold on, something. Got it. Okay. So my name is Takashi. I'm one of radiologists at the University of Minnesota, specifically in musculoskeletal imaging. So honestly, I'm not sure exactly if this is the right amount of a detail or maybe too much too shallow. I will appreciate your feedback afterward. Today, so I'm going to briefly talk about the bones and soft tissue tumors from radiology perspective, about 10-15 minutes. So it's going to be quite a bit of material. So I have to kind of like condense it down. So let's get started. Let me see if I can go. Generally speaking, there, as most of you already know, there's multiple like imaging modalities, including X-ray, CT, MRI, ultrasound, and nuclear medicine scans. There are all of these are relatively useful in the MSK imaging, depending on some types of pathologies. Certain modalities aren't that useful. A good example is probably something like looking at the intracranial pathologies. X-ray is not going to help you at all. But in the MSK setting, I think all of these have a potential role to play a certain extent. For example, X-ray is actually very useful in the MSK pathologies. Some of the bone tumors are actually relatively pathognomonic using X-rays, and X-rays are also useful looking at some calcifications, which is we kind of come back to later, but basically calling a matrix. And then when you look at the matrix, that would narrow down the differential diagnosis. And sometimes the MRI, even though much more expensive studies, actually X-ray may be able to tell the matrix a little bit better than MRI in certain situations. For example, this is an example I grabbed it from the Radiopedia, which is one of the radiology website. This has a relatively classic appearance of a ground glass matrix. So based on this, and then proper clinical history, this will be probably most people would call this is fibrous dysplasia, and down with it. Then when we move on to CT, there's a bunch of different reasons we use CT, but in many situations, MRI is superior to CT, except when you're looking for some fine calcification, MRI versus CT, CT will be actually superior. Radiograph, I've already kind of touched on it. It is good to look at the calcifications, but CT having better resolution, it actually shows the better calcification. This is a real case from our institutions showing the radiograph. You can still appreciate some faint calcifications here, but CT, nobody's going to question there are multiple calcifications, and these are basically what we expect for a chondroid matrix. And based on that, we would, as a radiologist, probably would leave this as some sort of chondroid tumors, and then putting the other aspect of the clinical and then some other areas of imaging, we might actually say this is most concerning for chondral sarcoma. MRI is probably, it's the latest and greatest, obviously. Usually does come up with a set of different sequences. As this is tailored for medical students, I'm kind of trying to simplify this quite a bit, but in the big picture, when you scan the MRI, unlike the CT, every single set of images that you're going to scroll through, they are independently acquired. CT is usually basically you acquire once and then they can reconstruct it in different planes kind of deal. So with that in mindset, when you have a couple of different sequences in the MRI or sets of data, they do try to tell something a little bit differently. In a big picture, what we call T1 weighted images, basically every single image in the MRI generally have what we call the T1 and T2 parameters. It's kind of did in the physics, so I'm going to skip that. But usually when they're scanning it, they try to basically weighting toward one direction versus other. So if something's T1 weighted, it basically have more property of a T1 than the T2, and then T2 weighted more property of a T2 than T1. So when you're looking at that, we usually say that T1 weighted is a good for anatomy. So we call it anatomic sequence. T2 related sequences, we call the basic pathology sequences. And that's mainly because when you have a fat showing up as bright, T1 weighted sequences really separates out the normal structures pretty well. You can basically even see a nerve, sciatic nerves, you can see vessels, you can see muscles, bones, and then subcutaneous tissue, and then you can see nice separation by the tissue planes. And then when you use the T2 weighted sequence, often we do a suppression because you're looking for something that's pathology, or what is a pathology in the MRI. Usually human bodies can actually only a few different ways. And then from an MRI perspective, it's usually related to the edema-like changes, basically, whether it's related to the cellular level of ATPase failing, and then basically intracellular, like a swelling of the tissues, versus extracellular splitting of the fluid because of a necrosis or whatever. Usually basically something that relates to edema or fluid. And that shows up right on T2 weighted sequences. And that's why it's really considered as good pathologic sequences, because you're usually looking for something bright. Having said that, it will loses the some resolutions, especially like tissue plane distinction. So this is not a nerve here. You really can't see a nerve in the normal circumstance in here. It's just a way the sequence is. So you want to use these in combination. Contrast is very useful because the contrast is basically typically in these settings or tumors, you're talking about the intravenous contrast, because it's basically the general belief is maybe tumors are hypervascular for their growth purpose, and then therefore it enhances. Now, one thing we have to basically be careful is not every enhancing lesions are tumors, and not every tumor enhances. So it doesn't mean necessarily it's pathognomonic by any means, but it is very helpful, especially if the original tumor confirmed histologically is hypervascular. Well, metastasis probably acts the same way. So giving contrast is helpful. Also, there are type of tumors that actually almost looks like a fluid cyst, and then or maybe heterogeneous, but it turns out to be hematoma. Either way, should not be enhancing internally, because that's not a hematoma or cyst does. So giving a contrast in those situations and then seeing enhancement tells us, well, it's not a hematoma, it's not a cyst. So you gotta start worrying about it. So these are kind of three basic sets of MRI that we usually deal with, and there are a bunch of different variants of these. So general, like a rule and the big picture, obviously there's way more detail than this, but generally when we're looking at bone tumors, we try to basically think about like on the kind of like a few different aspects. Well, obviously clinical information is crucial, and that's where the lots of information comes from the clinical side of it. But one of the things that we use, for instance, is the age. And then certain type of tumors are much more prevalent in a certain population, but ages, well, for instance, like if you are over 40 years old, statistically speaking, mesenchymal myeloma is most common actually in the bone lesions, generally speaking. Now, obviously, sclerotic lesions typically not show up with myeloma, but if it's lytic lesions and then they are over 40 years old, for testing purpose, probably mesenchymal myeloma is not, but if you're in the practical setting, it's probably mesenchymal myeloma is most common. And then you try to say the lesion basically looks lucent, which is basically lytic, or is it sclerotic, or is it mixed? So that would also distinguish certain characteristics, because some tumors likes to give a sclerotic metastasis, like a prostate or breast cancers, whereas other tumors may like to do lytic, like the renal cell cancer. And then we also try to look for the internal matrix, meaning that if it's what does a lesion looks like? Is it dense? Is it like chondroid, osteoid, or maybe it's neither and it's fibrous? So in this particular case of example, again, it's from also our institution. This is very dense here. This is pretty consistent with the osteoid matrix. So what's osteosarcoma? And then the general rule for the soft tissue approach is a little bit more very similar, but it's also a little bit more differently because of a little bit more location wise. So we're going to use the location first. Well, certain locations actually give you a certain type of differential diagnosis. Basically, if it's very classic location and a classic imaging appearance, then that may be just slam dunk and maybe perhaps do not touch lesion kind of deal. If the structure or the mass is maybe adjacent to the tendon, then we actually basically more worries about the giant cell tumor of tendon sheath kind of deal. If it's intra-articular, statistically speaking, an intra-articular tumor is very unlikely. It's possible, but it's very unlikely. So first thing we're going to start thinking about the inflammatory process. This is one of example. You can't see it well, but this is a basic nerve, sciatic nerve, and then the lesion itself is coursing along the nerve. So you're going to basically normally think about it. Well, it's a lesion is in the nerve. What is it? Well, it's probably most likely nerve sheath tumor, whether it's malignant or the benign would be other differential, but you're going to naturally think about this as a nerve sheath tumor. And then you're going to use a different kind of as we test on a T1, T2 kind of deal. And depending on the signal characteristics, you will basically try to use those findings and then narrow down the differential diagnosis. Not everything is useful. In fact, most of the pathologies are usually T1 dark, T2 bright. So if you have those two combinations itself, it's usually not helpful. But certain situations that actually goes a little bit different from that basics, you may actually be able to use that as guidance. If it's T1 bright, it might be fat-containing lesions or something else, but there's relatively narrow differential diagnosis from that perspective. This is basically a T1 bright, fat-like lesion inside of a muscle, most likely some sort of fatty tumor. This turns out to be atypical lipomatous tumor. If it's T2 dark, it's really dark, then you would basically think it's not a typical lesion. Well, you're going to think of maybe it's fibrosis, calcification, hemoserine depositions. Again, it has its own differential diagnosis. If it's T2 bright, again, most tumors are like that. But if it's really, really bright, like a cyst looks like bright, then you start thinking about something, maybe it's fluid filled, or the kind of like a scary kind of differential for us, it's basically myxoid type of lesions. And that's where the contrast could be helpful. But these would be also relatively narrower differential we may be able to provide. This is a basic example of the myxoid tumor. Looks free blight, maybe a little heterogeneity inside, so probably most people hoping not going to call it just a cyst, but relative brightness looks maybe cystic. But we will probably consider about this is myxoid, but giving a contrast, nobody should be calling a cyst at this point because it's a lot of internal enhancement. And this turns out to be one of the myxoid type tumors. And then obviously radiology can play a role in the other areas. If you see a lesion, how's the neurovascular involvement? Is there any additional lesions? If it's looking for distance meds, that's where it comes to the different modalities beyond the MRI or regular CT scans, PET CT, maybe bone scan, maybe CT cap or the lung CTs. And then when you have a follow-up imaging, we try to basically assess the imaging response. Certain types of scans try to use certain criteria, like RECIST criteria is one of those. If it's lymphoma, they have their own criteria kind of deal. In conclusion, basically, for us to be able to come up with the best imaging differentials, we try to use a combination of multiple imaging modalities and also clinical context all together, and then try to come up with a relatively narrower differential diagnosis whenever we can. And that's pretty much it for a radiology perspective.
Thank you so much. Anybody have a question? We depend really heavily on our radiology colleagues to help us out. They lead us down the right path of where to go with these sarcomas. So thank you so much. Anybody on the line have a question? I guess you can raise your hand. I'm not sure where that would be.
I'm not sure how relevant it is. I'm kind of curious, are sarcomas ever found as incidental findings on scans or identified sort of that way? How common is that, or do we know how common that is by any chance?
Chris is going to answer that as soon as we see him.
Yeah, we do a lot of scans on a lot of people, and we do spend significant time sorting out incidental findings. Occasionally they're malignant. One of the challenges is that soft tissue sarcomas usually don't cause pain. And so everyone assumes if something's cancerous, it ought to hurt for some reason. That's generally true in the bone tumors, but soft tissue sarcomas don't cause pain. And so they absolutely can be found incidentally. And I couldn't give you a number on how often that happens, but we see it regularly. We do spend time trying to sort out between the benign and things and malignant tumors when that does come up.
Great,
Great.
thanks.
Any other questions? Okay, our next speaker is Dr. Hurley, if I have that right. He is a medical oncologist at Health Partners at Regions, and he's going to start us off with an overview of sarcomas.
Thank you, Kate. Yeah, so my name is Randy Hurley, kind of a general medical oncologist at Regions Hospital in St. Paul that has an interest in sarcomas. I also actually have a hobby in medicine, global health, and kind of share that hobby with Dr. Dusenberry in terms of global cancer care. And I think what I want to do in the next 15 or 20 minutes is to try to get you excited about why you want to learn about sarcomas.
Full screen.
Okay, that is beautiful. You know, when I speak with oncology fellows in my clinic, I actually tell them that breast cancer is the most complicated thing we do. And the reason it's the most complicated thing we do is that we've made it complicated. Not that it's actually all that complicated, but we've actually made, I'll explain this in a second, we've actually made it complicated, whereas sarcomas, as you can actually just get a sense from our last talk, truly are complicated. I mean, they don't need to be made complicated, they truly are complicated. What do I mean by that? Well, in breast cancer, I mean, there's really only two histologic subtypes. I mean, infiltrating, ductal, and lobular, and really four main molecular types: luminal A, luminal B, triple negative, and HER2. And so fairly straightforward, where there are a whole plethora of different subtypes of sarcomas, both bone and soft tissue sarcomas. What I mean by saying that we made breast cancer complicated is that in every stage of the game with breast cancer, we kind of ask the patient what they want to do. You know, so a woman comes in with a breast lump, and we say to her, "Oh, do you want a lumpectomy or mastectomy?" And she's like, "Oh, I just want whatever's." And we don't care. It doesn't matter what you get. Both are equal. And so we have to spend time talking with them. And of course, patient choice is really important in oncology, but we have to spend that time kind of helping people navigate through that. We find they have a hormone receptor positive breast cancer. We do some molecular typing and then tell them, okay, we think your risk for recurrence is X, Y, or Z. Do you want chemotherapy? Do you want hormonal therapy? Do you want either, both, or neither? And we talk people through that. Another great example is a drug called neratinib was FDA approved for breast cancer because it improved the disease, not overall survival, disease-free survival from 91% up to 94%. If you took a year of a drug called neratinib that causes horrible diarrhea. So here you have to sit down with a woman and talk to her about, do you want a drug called neratinib for a year that improves your response rates just a little bit? Whereas soft tissue sarcomas are rare and incredibly complicated. You will see breast health centers in every hospital in the Twin Cities. Every hospital in the Twin Cities has a breast health center, but sarcoma care is so complicated, so unique, so rare that it really does need to be concentrated in specialized centers, which you'll also see. Sarcomas are tumors of mesenchymal origin, as you know. There are a handful of bone sarcomas, osteosarcomas, chondrosarcomas, etc. And then a whole plethora, literally 50 to 100 different subtypes of soft tissue sarcomas, many of them named after the tissue origin, but not necessarily. You know, we've already heard a little bit about liposarcomas from adipose tissue and leiomyosarcomas from smooth muscle, etc. Gastrointestinal stromal tumors, I think, are absolutely fascinating. They are, so if you think like every mesenchymal cell in the body could potentially go bad. And what I love about gastrointestinal stromal tumors is it's the cell of Cajal that goes bad. What the heck is this? The cell of Cajal is the intestinal pacemaker cell, the cell that leads to peristalsis in the gastrointestinal tract. And you can develop a sarcoma of that cell called gastrointestinal stromal tumors. And lo and behold, incredibly fascinating. I could go on and on about the different biology and whatnot of sarcomas, but they truly are complicated. You think about the pathology of sarcomas. I'm not a pathologist, but I do spend time looking at pathology. And just look at that slide, comparing that small round blue cell tumor of Ewing's sarcoma with a completely different histologic pattern of a gastrointestinal stromal tumor, a spindle-shaped tumor with low mitotic activity. Of course, our pathologists use a number of things to characterize sarcomas: histology, immunohistochemistry. A great example of that is using CD117, the c-KIT marker on gastrointestinal stromal tumors to make that diagnosis. And more often, pathologists are using molecular techniques to classify sarcomas. Great examples looking for certain chromosomal translocations that are characteristic of Ewing sarcoma or synovial sarcoma. I also think that sarcomas are fascinating from a historical perspective. This photograph of this chicken, I think, is fascinating. This was in experimental medicine, the Journal of Experimental Medicine, in 1911, over 100 years ago. A guy by the name of Peyton Rouse was able to demonstrate that he could take a cell-free extract from that tumor, that sarcoma on that chicken, inject it into another chicken, and develop another sarcoma. This was long before anyone even knew what viruses were. He eventually got the Nobel Peace Prize about 4 years later for identifying the Rouse sarcoma virus, an RNA virus that causes cancers. Another researcher, Howard Tim, from actually my alma mater, the University of Wisconsin, used the Rouse sarcoma virus in the 1970s to identify reverse transcriptase, which we now associate quite a bit with the HIV virus. So kind of just fascinating how sarcoma research and whatnot has played a role in history. James Ewing, a prominent pathologist from 100 years ago, wrote the first comprehensive textbook of pathology with over 479 illustrations. And of course, his namesake is on Ewing sarcoma. I think it's interesting, medical students these days, I kind of think of you guys kind of entering medicine with this global viral pandemic of COVID-19, And of course, COVID-19 has been associated with a whole bunch of things. Thankfully, not sarcoma, or at least as far as we know, not sarcoma. But when I was entering medical school, there was this weird viral pandemic coming around called HIV. And interesting, little did we know that HIV was actually first described as a funny sarcoma and a funny pneumonia pneumocystis in men in New York City and California. This is a copy of the first NMWR case report of this epidemic now 40 years ago. I think of, so I've been in oncology for way too long now, and I think of oncology as a series of eras of treatment, at least medical oncology has been. I can remember way back, the interferon era back in the 1980s, we thought that interferon, a naturally occurring substance, was going to be the cure-all for cancer. We entered the monoclonal antibody era in the 1990s with drugs like Rituxan and Herceptin, and that actually spawned what I'll call the angiogenesis era, where we thought that inhibiting vascular growth into cancers would be the cure for cancer. And then at the turn of the millennium here, we entered the tyrosine kinase era. And there was actually a St. Paul native, Brian Drucker, working at the University of Oregon, synthesized a small molecule tyrosine kinase inhibitor that was found to be able to actually cure, or at least put chronic myelogenous leukemia into remission by inhibiting that BCR-able tyrosine kinase. And of course, imatinib made it on the cover of Time magazine in 2001. There's new ammunition in the war against cancer, and these are the bullets, this drug called imatinib or Gleevec. And so we actually thought then that we were entering this new era where this drug Gleevec would treat a whole bunch of cancers. The interesting thing about it is there's only one other cancer that it's really, really effective for. That's a sarcoma. Gastrointestinal stromal tumors are incredibly responsive to imatinib or Gleevec. Our current era that we're in, so we've still in the tyrosine kinase era in medicine, we're now in the immune therapy era. And in the last 5 to 8 years, we've understood the use of PD-1 inhibitors in cancer therapy, immune checkpoint inhibitors, and they found a role in treatment of all sorts of cancers: melanoma, kidney cancer, lung cancer, Hodgkin's disease, all sorts of stuff. But unfortunately, not very much in sarcomas. However, the concept of immune therapy in sarcoma, immune therapy in cancer therapy, we can link back to sarcomas. Dr. Coley, back 130 years ago, was taking streptococcal lysates and injecting them in the periphery of sarcoma tumors, and identified fairly substantial responses to that. I kind of wonder back then, I wonder if there was like an IRB review for this, for that clinical trial or not. It's something probably wouldn't have been able to ever do today. But the whole concept of inducing an immune response to treat cancer actually does date all the way back to sarcoma therapy. Unfortunately, our current PD-L1 treatments, like drugs like Opdivo, don't have a major role yet in most of our different types of sarcomas. So sarcomas have kind of a varied epidemiology. They, of course, can arise de novo. There's a whole bunch of genetic predispositions. Lee-Fraumeni syndrome is probably the classic, but even the retinoblastoma and neurofibromatosis obviously predisposed to sarcomas. There are radiation-induced sarcomas. The most prevalent or obvious is angiosarcomas induced by radiation, thankfully very rarely in women who had breast cancer. There is something called Stewart-Traves syndrome. I've actually seen one case of this where chronic irritation from lymphedema can actually cause angiosarcomas in the lymphodematous extremity. And of course, we've already linked the viral etiology of cancer with Kaposi sarcoma. Kaposi sarcoma is caused by the human herpes virus 8, HHV8, that is seen in patients with, well, it can occur in a bunch of issues, including patients with HIV. In terms of clinical presentation of soft tissue sarcomas, I think that the difficult part about soft tissue sarcoma presentation is how rare they are compared to more common benign masses. Some of the work that other sarcoma scholars in this program have done have queried primary care providers on how often in their career have they ever identified a soft tissue sarcoma. And some people practicing for 30 years have seen maybe 1 or 2 soft tissue sarcomas in their lifetime, in their career. So the hassle we have here is that these are so rare, and our primary care colleagues are really at a disadvantage of how to discern what a potentially benign, more common soft tissue mass is that could actually be a more serious malignant soft tissue sarcoma. And you can imagine that there is a huge issue with delay in identification and delay in presentation of soft tissue sarcomas. To that end, our colleagues at Rein Sarcoma have been doing a whole bunch of work. In fact, this whole program, Rein Sarcoma in itself, and specifically the Red Flags program, is designed to try to increase awareness for medical professionals to help improve the early diagnosis of sarcomas. And these Red Flags sarcoma cards are ones that I've passed out at all sorts of places to help improve that early recognition. 1 or 2 just other quick things to comment on. So this looks like a really busy slide. And really the 2 points of what I want to get out of this for you is that number one, cancer care has become very algorithmic, very algorithmic. And you too can, as a medical student, can learn those algorithms. In other words, I invite you to go to nccn.org. The National Comprehensive Cancer Network has an online resource that is free. You have to sign up with an email to get to it. But it literally is really the algorithms that all of us use to decide how to treat almost any form of cancer. In fact, I would say this, that quality of cancer care or quality of provision of cancer care is directly linked to how closely you follow NCCN guidelines. And so you can look up just about any type of cancer, including all sorts of different types of sarcomas, and understand what the algorithms should be for evaluating that. I think well, the most useful thing on this is that adequate imaging, careful planning, and use of multidisciplinary treatment planning for the diagnosis and evaluation of sarcomas. Real quickly, I think most of you are aware that for most cancers, we use the TNM staging classification to stage tumors, tumor node metastasis. I would have to say that for sarcomas, this is not quite as useful as it is for most of the other cancers that, as a general medical oncologist, I deal with. I think that we oftentimes think of sarcomas as either localized or metastatic. Only rarely do sarcomas metastasize to lymph nodes. It's kind of a peculiar thing about sarcomas. Doesn't mean that they never do, but it's not very common. And the most common organ site for distant metastases is typically the lung. The one thing I do want to point out about this is that in one of the unique things about sarcomas is that in the staging, actual histologic grade, so how the pathologist classifies this as what appears to be an indolent, slow-growing abnormality or a high-grade, very bizarre-looking tumor, that tumor grade with a number of criteria, including things like nuclear pleomorphism, mitotic index, etc. That nuclear grade actually influences the stage of the tumor. As you can see that for higher grade tumors, that's that G1 through 3, there's an upgrading in the tumor stage as well. So to quickly summarize here, sarcomas, rare tumors, incredibly fascinating, intrinsically complicated. We don't have to do anything to make them complicated. They're complicated on their own. Diverse subtypes and pathogenesis, historically significant, especially when evaluating soft tissue masses where it's a high index of suspicion. And then we've talked about NCCN as a great resource for you. So questions? I think it kept it to under 20 minutes.
Yeah, no,
Yeah.
great.
Awesome.
Are there new soft tissue sarcomas being discovered?
I should say that there are new soft tissue sarcomas that are being better characterized. So things that we've lumped into larger groups have been split out into more better defined pathologically, particularly molecularly defined subtypes. So the answer is yes. So that list of 50 to 100 different subtypes is growing because we're getting better at subdividing previous categories into more specific entities.
Well, it looks like here. Can some smart computer person come help me? We go back to the lab. We're going to have Dr. Ogilvy talk now if we can get his slides figured out. Here somewhere. Oh, I'm not sure I put it in correctly. It's a weird one. Let me look here. I don't think I put it in correctly.
Gotta pull this thing out.
Oh,
Yeah. Oh, that's why.
oh, it made a good noise. Oh, right.
Oh, fantastic. Andy Hurley, so I'm hopefully everything said was the same video. So yeah, so I'm a medical oncologist over at Regent's Hospital. So of course I trained under Dr. Stubitz years ago. So he was my mentor 30 years ago. So yeah. He had told me you were coming, so I'm so glad you introduced yourself. Looking forward to collaborating with you. And
Yes.
Share. Oh, right.
Okay. Yeah.
Just great.
Yeah.
Well, I really appreciated both of those presentations. I love the imaging. I spend a lot of time looking at imaging and really rely on the medical oncologist to help us out in so many ways. But try not to think about the staging too much. I will agree with what Dr. Hurley said. We tend to think of the tumors as metastatic or not. And the imaging we can make the diagnosis often of the bone sarcomas, but the soft tissue sarcomas are much more difficult because there are dozens of them and they look similar. But a lot of those little subtleties I'm looking at when I see patients, and for the most part, I have done your surgery in my mind before I meet you, 95% of the time. So I will look at it, try to figure out what it is and what needs to be done, and then I go and talk to the patient. So I'm going to talk about sarcoma surgery a little bit today, the decisions to do that, the planning, execution, and the follow-up. So this is all the fun stuff. Oh, that's right. Okay, so the decision whether or not to do surgery and what and the details of surgery really depends on the pathology, and for soft tissue sarcoma surgeries are really the mainstay of treatment. We do chemotherapy in many of the high-grade tumors, and we do radiation to decrease our risk of recurrence, but we haven't figured out how to avoid taking them out quite yet. Ewing sarcoma, we can get cures with chemotherapy and radiation, but we do surgery whenever we can get around it. So we do surgery for pretty much all sarcomas whenever we can, and that's connected to curing them, getting them all out. And negative margin surgery is our goal. We want someone who has the ability to benefit from surgery, especially if it's a big surgery. So when it comes to people with metastatic disease or large tumors, are they going to be able to benefit from the surgery? I have a patient in the hospital right now with multifocal disease and a big tumor, and it's not clear that she'll benefit from the surgery. So anatomy, and we want to do it with the acceptable morbidity. You think, well, if it's going to cure me, just about anything is acceptable. And it kind of comes into the patient I have in the hospital. It wouldn't be curative, and it was very morbid. So that's always a difficult decision. So many times we do wind up doing big surgeries. The first surgery we do in some people is the biopsy. And for soft tissue sarcomas, we try to do a needle biopsy in clinic, but for many of the tumors, we wind up doing a surgical biopsy, many of the bone tumors especially. And there's a couple principles in doing that. We don't want to burn any bridges. That is, I don't want to create a problem like a hematoma or contaminate tissue that I can't undo. And then I want to get good tissue so that I get an actual diagnosis. And if I don't get good tissue, or if somebody else does it, I can go do it, as long as we don't contaminate vital structures such as the vessels and nerves. We found over time that there's fewer complications if sarcomas are biopsied at specialty centers, and that was kind of alluded to, that people seem to do better if they're treated at centers with experience. All right. So how do we actually do that? How do we limit their contamination of surrounding tissue? Well, we make small incisions, avoid making flaps to keep the wound nice and dry, good hemostasis. We go through the edges of muscle sometimes to contain any tumor or bleeding that has the tumor cells potentially in it. We do multi-layer closure. I rarely put drains in, but if we put them in, we put them close to the edge of the incision, because in theory, wherever they pass through could be contaminated. And I make an incision along the line of where I would make an incision to remove the tumor when I do a biopsy. So I want to be able to extend that incision and not cross over multiple different muscles and neurovascular structures. We want minimal contamination with a good extendable incision. And we often will do a frozen section while we're in the operating room just to confirm that we've got good tissue. Never ask the pathologist if we have enough tissue, because they always say they would like more tissue or something. Kind of like ask the radiologist, they want another sequence on it. All right, you always will say yes. You know what the answer is to that. So we try to get a good amount of tissue. And we don't usually expect an immediate diagnosis. There are some benign aggressive bone tumors. That's very helpful. We want to get that diagnosis at that moment so we can go and treat it while the patient's asleep. And for bone sarcomas, timely treatment can impact the results. And so we want to get that started quickly. And so if we can get some information on that, and that's what it looks like, then we can talk with a medical oncologist and get the staging all teed up. So we really press them in those cases, but usually just to make sure we've got decent tissue, there's a little core sample of the bone that's a breast cancer. All right, so planning. We want to think about timing. We want to have the right imaging. I do this little rehearsal in my head. We want to make sure we have blood products and we can get that tumor out and rebuild the leg or arm or body part if needed. So soft tissue sarcomas, we want to make sure people have recovered from their neoadjuvant chemotherapy. And that's, for me, a couple things. I would like normal amounts of white blood cells. I can give people red blood cells pretty easily, and platelets if I have to. I'd like those up, but I don't always wait for those. And I don't like the agents that inhibit wound healing, especially if I have a big metal prosthesis underneath. If people get an infection of that, it's going to threaten the whole limb and kind of undermine the whole purpose of the surgery. So we want good white blood cell count and we want wound healing to be available. So we need a little space from the chemotherapy. And when people have preoperative radiation for wound healing issues, also I tend to wait about 4 to 6 weeks, closer to 6 weeks usually, but and that's because we worry about wound healing. And if we're given radiation afterward, we want to get those wounds healed in timely fashion so they can get the radiation and get back onto chemotherapy. Most of the bone sarcomas are going to get chemotherapy after surgery. So we need to do a good job of closing things up so that they heal in a timely way. And that can affect our decision making on how we proceed. As I alluded to, an osteosarcoma, we know postoperative delay can worsen prognosis. So we have to take that into account. Some people, pelvic implants, for example, they may need a custom prosthesis, and that can take 3 months to make. So you have to plan that out and be ready for that, and try to time that with their pre-surgery treatment, such as chemotherapy. So imaging and getting ready for, this is like a brain, this guy's shoulder. This is one of my favorites. So this guy had a multiple hereditary exostosis and he had a chondrosarcoma. See on the top of his shoulder, but that image looked like a brain. I love that one. So we want to see the whole tumor or the whole bone. If it's a bone tumor especially, we're looking for landmark structures to judge the extent of the tumor intraoperatively. I'm kind of deciding what stays and what goes and what things I might have to move and deal with. And do I have to deal with the brachial vessels going to the arm on that one, or is it just sitting on top of the latissimus muscle? I need to look back and forth through the images to be ready for whatever I need to intraoperate. So as I mentioned, the goal for sarcomas is to remove the tumor with negative margins. So a little bit of normal tissue around that. Usually if it's a radiated soft tissue sarcoma, we might be happy with 1 millimeter. If it's a unradiated soft tissue sarcoma in a child, we love to have a couple centimeters, and for bone marrow margins, we'd love to have a couple centimeters. So not all the margins are the same, but we try to get that wide resection. The other types of resections put us at higher risk for local recurrence of the tumor. The intralesional, like a partial excision where you're inside the tumor kind of scraping it out, I would argue that has no role in sarcoma surgery, perhaps with the exception of retroperitoneal liposarcomas, which a lot of their morbidity comes from their mass effect. You reduce the mass, and that can help people out quite a bit. But a lot of times you wind up losing a lot of blood, and the tumor recurs rapidly. So sometimes in palliation situations, I think this person's in the hospital right now, a patient of mine, it's tempting to want to do that, but it's rarely helpful. And so we need to make decisions about margins. What structures are going to stay with the tumor? Am I going to sacrifice this nerve? Got a guy right now, probably needs to sacrifice his femoral vessels. Okay, vascular surgery ready for that. And they need to do whatever studies and have whatever materials they need So this requires kind of communication and preparation. It's much more difficult. You know, they'll run over at the last minute and do what they can, but they may not have everything that they want if they don't know about it. So reconstruction for the bone, endoprostheses are great now. In the 70s, when we invented chemotherapy, we're also inventing endoprostheses. They're kind of custom made. And while you got your chemo, we made you a prosthesis. But if the tumor grew, that could be a problem. So now they're more like Legos. We have a whole sets and we can put them together and make them different lengths and sizes that we need. It's fantastic. If you want an allograft, you got to order that ahead of time. And usually they'll send you some pictures of a bunch of different grafts and you try to get them sized just so. There's places that have a more sophisticated CAT scan matching algorithm for getting just the right allograft to do the reconstruction. You need to have a backup plan. You know, if something breaks, if the tumor's grown, if the allograft doesn't fit, what is your fallback? And soft tissue management. Do you need a muscle flap? Do you need skin graft? Do you need to have plastic surgery come in and do a free flap? Again, that's something they like to tell them ahead of time and get them prepared for that, both in terms of talking to the patient about what that involves and being available on their schedule. The wound vacuum is very powerful, and we are using that in superficial tumors where it's difficult to tell the margins, even when we're far away from the tumor. And sometimes we'll put on the wound vacuum, then come back a different day and skin graft those areas or advance the margin, depending on how good a job we did at getting it all out. So, and thinking through the surgery several times, and sometimes I will do that and I'll come up with like, oh yeah, what am I going to do with this? Or how about that? I'll come up with some different things. I had a tumor in the supraspinatus fossa in the shoulder that went right up to the shoulder joint and underneath the acromion. And it's a difficult anatomic area. Like, how much bone am I going to remove? What am I going to do to reconstruct the labrum of the shoulder, and how do I get that out of there? This patient had chemotherapy and radiation ahead of time, so I had about 6 months to think about that one. So I remember spending kind of going back and forth about that. So, and you have to review anatomy if you're in a place that you don't go very often. Blood products I mentioned. Some people have antibodies that have had surgeries beforehand, and it can be difficult to get the blood you need on short notice. So that's something that you want to be aware of, especially if someone's had surgery previously and you expect that to lose a lot of blood. Blood thinners, we want to avoid things that disable platelets, and there's a whole host of blood thinners out there. Rarely we would let people be on a platelet inhibitor for a small surgery if it was absolutely critical for their heart. Often we, if they need to be on that temporarily, we would wait until they could be off it for a short while. And then during surgery, you want to help anesthesia keep track of the blood that you're losing. And you communicate about that because they want to check the coags. And if you're losing enough, and you might need to give additional blood products such as fresh frozen plasma or platelets. But it's really important to have that kind of ongoing back and forth with anesthesia, especially as that blood loss creeps up. So something you want to watch out. Sterile technique we use in all surgeries. We're going to draw the entire incision on the patient. I usually don't do that in the pre-op holding area, but I'll do that right immediately before we start surgery and draw it all out, and possible extensions to the surgery, extensions if I wanted to, if I thought like I needed to get a little longer. So you may have a lot of ink marks on your arm or leg.
Is that arrow cut here? Is that the arrow?
Yeah, I don't know where that arrow came from. So usually we put our initials on the area, and my last initial is O, so it's really helpful. It's kind of circle the tumor or something, and I put a little first initial in there somewhere. But yeah, I don't know where the arrow came from on that one. Sometimes the patient marks our own arms. Don't do that. That creates confusion. All right, so the actual act of taking these out, well, soft tissue sarcomas especially, we don't want to squeeze the tumor, so we don't use these elastic exsanguinating wraps. I'm worried about that. When we measure for our bone cuts, we get out rulers. I talked about a 2 centimeter mirror margin. We're going to look at different bony landmarks to judge that off of using our correlating what we see in the operating room with the pre-operative scans. And the soft tissue margins, I said some barriers are better than others. If I peel something off of a cortical bone, the tumors don't penetrate that very well typically, but if it's just a muscle or subcutaneous fat, that's less of a good barrier to tumor infiltration. And as I also mentioned, sometimes we need larger margins if we're not planning radiation, such as in pediatric patients. After we take it out, we irrigate it good, we try to dry it up, and we use drains, especially in radiated tumors, because they have some lymphatic trauma from the radiation, so they'll get seromas typically, if not universally. And that can put some back pressure on this slowly healing wound, so we'll often leave drains in radiated soft tissue sarcomas. And then we got to orient the tumor for the pathologist, because if they say, oh, if we have a positive margin, we want to know where that was. Was it superficial? Was it deep? Was it up against the bone? All right, I'm not going to take bone out, or I'll keep an eye on it, or maybe I'll go back and take more tissue. So we usually put little sutures on the tumor to do that. There's little kits to put different colors of ink on it. The pathologists do that, but there's even one that surgeons can desire. Rebuilding things. As I said, we have endoprosthesis that we can use. We have trials that we use during the surgery to kind of say, this one's long enough. I try to get the legs the same length. And then we cover with muscle and skin graft as needed. We want to avoid excess tension on the skin, especially if it's radiated. And I mentioned the use of a wound vacuum and delayed grafting, which helps us sometimes if we're concerned that we might have positive margins. I think we might have to go back. I'd rather not have a skin graft put in an area that's likely to have a positive margin than just have to go back and do a second skin graft. And a couple of weeks afterward, we're checking this incision for the radiated wounds. If we use staples or sutures, we'll leave those in 21 days. I'm not doing that much anymore. I talked about drains. We want people to get moving. And we worry about infection, especially if they have an allograft or prosthesis. We're very aggressive about washing something out early and putting people on antibiotics. It can be more conservative if I have good soft tissues below the wound. And therapy is a big part of what we do as well. Thank you very much. I will be happy to answer questions. That was a lot.
Anybody online have a question?
I have a quick question. My name is Nia, and I'm one of the scholars. I actually was a pathologist assistant at the U of M, so I got plenty of Dr. Closey's and Dr. Ogilvy's bone resections. I guess my question is the resections that happen after, which is the majority, I guess, after like chemotherapy, is there a lot of soft tissue reactive change? Is it harder to like visualize the mass and like maybe extension of soft tissue? Like I'm thinking about like the big osteosarcoma resections that you can sometimes see. Right.
So we restage people close to the time of surgery, and they get re-imaged throughout their treatment. And in Ewing sarcoma, for example, is notorious for big soft tissue masses, and sometimes those will go away almost entirely during chemotherapy. So there's huge changes that take place on that front. An osteosarcoma a little less so, and that's often blamed on the bone matrix within that soft tissue mass. That this kind of matrix is not going to go away, so soft tissue mass tends to shrink not quite as much as Ewing's, but the Ewing's changes are profound. But soft tissue sarcomas, they'll some of them shrink reliably, myxoid liposarcomas. Many of them will get bigger. And I've had that trouble outside radiation oncologists and patients when they get larger. That doesn't bother me a bit, because I think, this is likely to happen, is there to get smaller. And they're often dead, but they swell up and take on fluid. And so the reaction in the soft tissue sarcoma is a little unpredictable. In terms of making surgery easier, Ewing sarcoma is a lot easier without that soft tissue mass. And for soft tissue sarcomas, it's actually easier too, because the pseudocapsule gets a little tougher and it's easier to get close to them without them exploding. A lot of times you're literally wrestling with the tumor. I'm feeling the edges of it, trying to divide the muscle with soft tissues around it. You're constantly feeling and working around it. like, well, you know, do I need to take this muscle? Maybe not, maybe I'm far enough away, or I'm gonna have to sacrifice this. So it's just it's a little wrestle the whole time. And you're moving it and pulling it off and separating from the tissues. If it's really fragile, you're more likely to have a spill, which we see when we operate on it without radiation. So yeah, the pre-treatment makes significant changes, which affects the surgery experience.
Thank you.
I want to make one point that you didn't make, that you've made in previous talks, that I think is important for medical students, is that when you get out there and you're practicing, Chris always says you shouldn't try to take out something unless you're pretty sure you know what it is. I have been practicing for a lot of years, and I'm amazed at how many people out in the community, family doctors, dermatologists, general surgeons, will see a lump. They won't exactly know what it is, and they'll decide to try to take it out. And it's only when they made the incision that they realize, oops. We actually call these oops surgeries, and we get a couple a month still where it's a sarcoma, and it makes his job and my job a lot harder to know what to do next. So
They come out really easily. They have nice little pseudocapsules around them, pop right out. And when we go back and do wound bed resections, about 50% of the time we find microscopic tumor there. So, you know, I alluded to don't burn bridges. When it's easier to radiate something when you have a target, you know, and this is like the very simplified orthopedic version of it. And when you're radiating that target and a little bit of tissue around it, you're going to have less radiation to your normal tissues than if I'm just radiating a whole bed of what appears to be normal tissues with no tumor. And I'm not exactly sure quite where the tumor was, especially if they don't have preoperative imaging. So it creates some big challenges and long-term side effects.
So when in doubt, get an MRI to try to figure out what it is.
Yes.
And don't put a needle in something unless you're pretty sure you know what you're doing.
Yeah, very low threshold for getting MRIs. They're very powerful tools for telling you know, if you have a growth or not.
Any other questions? Okay, let's take a little break. How about 15-minute break, or is that too long?
Probably do 10.
Okay, how about a 10-minute break? We'll reconvene in 10 minutes, okay, Dr. Charlson? You're next.
That sounds good. I'll put my slides up and maybe you guys just holler when everybody's back.
Yeah, we'll stop sharing now. You can put yours up.
All right, thanks.
Thanks.
All of the satellite scholars have responded with pictures. I'm all very, very excited. People would humor me before we
Pictures of what?
themselves out. Like text of introductions, like we've got Madison, Rochester, Milwaukee. I've been sending pictures of all the students, so everybody
Okay.
kind of be in a little bit more. And you guys can tell me I jumped in on anything, so. If I could like pop everybody together for a mass photo beat.
Oh, you want to
Oh, got it. And then, yeah, just the back. Yeah.
Where are we these days?
Smiles with the eyes maybe, and everybody knows that we try to do our best to keep everyone safe.
And I wanted to introduce myself.
Yes.
Yeah.
Thanks for coming. Nice to hear.
Yeah, thank you.
I just joined.
Yeah. Senior sarcoma. So yes. So yeah, great.
Everyone together? 1, 2, 3. Thank you so much. Thank you for getting us all organized.
So well,
And it just,
and thanks for the food. I'm gonna go help myself.
Katie started this program in 2009. The Sarcoma Scholars and mentoring.
I'm good.
Like Dr. Hill, you guys were able to meet just a little.
Yeah.
bit.
Yeah.
Thank you.
Yeah.
Thanks. I was so excited,
Yeah.
like,
How's your work
the
going?
patients have been so.
Yeah.
Keep going. Yeah. Yeah. hope you had a vacation.
Yes, every now and then you gotta do that, to kind of keep yourself on it, so.
Yeah, yeah. No, I'm doing really well. Just enjoying life. Yeah, I'm trying to do a little good in the world, so.
Well, I think it's a piece difference on for sure.
Oh, yeah, no, it's fun. Yeah, I enjoy being at Sarcoma. Yeah, no, my life's good. I just came off a canoe trip. I went out to the well, it's my, I've done it all my life, so doing things that I enjoy doing and,
That's what you should do.
yeah, this is the first time I've been up there, well, they closed the border. Yeah, and I had, and so the last time I was up there was 2018, which was before this, so it was a bit of a challenge, but I have some good people with me and it's good, so. Yeah, I'm figuring it out. Yeah. Yes. What are you gonna do?
I'd like to go to Kenco.
Oh, canoeing. Yeah. Yeah.
Very, very hot.
Yeah, we were just there. It was,
Extremely hot last August.
yeah, September, last week. It was 80. We couldn't believe it.
Well, we had all this here.
Oh, yeah.
Cold and it was
Yeah,
in the 80s every day.
Yeah.
And there's no fires allowed.
No, that's right.
And,
Yeah.
we actually went swimming up there all the time. I never expected that.
And there was a lot of smoke in the air.
Oh, yeah, there were fires ongoing that
all those
actually,
fires, yeah.
we came out, they closed it, they closed it the Saturday.
Uh-huh.
The day we came out, they closed it
Wow.
for a while.
Mhm.
Fires.
Yeah. What's your talk? Very nice. I didn't do anything. You did.
We haven't met in person, I don't think. So, yes, I'm Katie. Yeah, nice to meet you. How's it going?
Good.
Have you been going to any of the Thursday morning conferences?
I made it to a couple, and it started getting harder when I started back through patients.
Yeah. I'm thinking we should maybe like that scholarship for second years.
Alex Nelson suggested to me that, he said, what if you open it up for next year to both, so you don't skip a year? And then the following year after that, so both being, incoming second and incoming third. Kind of a, and then, so the year after that.
I think it's
Yeah, and then we'll align ourselves with the other campuses and, yeah, you're running all the time, I think. Yeah. I'm correct to say you interesting radiation oncology. Yeah, that's what I thought. I didn't know that.
you want to come out with me.
That'd be great.
Oh, anytime. We're gonna do a rotation. I can't see who the participants are. There must be a way to look at that.
Maybe they're minimized up at the top right. I think you can. Yeah.
Here?
One of those.
Oh, yeah. can't see all 12 for some reason. Hi, Scott. I'm glad you joined us. I was looking to see.
I'm driving here, so I better keep my eyes on the road here.
Okay, good. I won't call on you then. Oh,
That's helpful. Yep, thanks.
I'm glad you joined us. Okay. We'll come back together here in a few minutes. Oh, the guy with the under sarcoma wants radiation. Going to,
Okay.
I think I'll give it a try in SBRT.
Always have an above elbow amputation, but
Yeah, he's not having any symptoms.
I know.
No. I thought maybe he was having some, and then it made kind of more sense to prevent him from getting worse.
Yeah.
But we, I put the pictures up side by side and how big it's gotten and or how fast it's changed from February to now.
Yeah, I mean, it's following the same course as the other one, so I'll need something eventually, but all right, well, hopefully that'll slow it down.
Or stop it from blowing it off. That's the plan. It's very, I want to be that way when I'm 92.
Yeah, very pleasant. Yeah.
Good hearing, he's nimble on his feet, he's taking care of his wife in the assisted living place. One minute, showtime. Who knows on, but it's right. Yeah.
Probably gonna call Claire today, wasn't it?
Or the cross, or the Claire.
Yeah.
Yeah.
How did you?
Good. Oh, it was really good. Yeah, today, you sound very impressive. Tells everything that you're doing.
You know, so you and I are just not like, mouthpieces. We're not, we need people who can show us off because we're such.
Yeah, literally. They did have some money about these scholarships. Well, they told me one. Maybe about 4. Well, they're gonna have to do it with Karaha. He's going to. So we're gonna have to ask.
He has.
Other than, I think some. They didn't focus anymore. It's mostly education. Yeah. Yeah. Yeah, so good. Okay. John, are you there?
I'm here.
I think is everybody back? Looks like it. I'm going to mute our room and you take it away.
You guys can see my slides?
Yeah.
Okay, thanks. Well, thanks for having me. John Charlson from Medical College of Wisconsin in Milwaukee, and I and Natalie Stratton are joining you from down here. I am an adult sarcoma medical oncologist. I guess what I mean by that is I treat adults. I'm not claiming to be an adult, but I treat adults. Going to follow up a little bit on what Dr. Hurley talked about, and then focus specifically on some chemotherapy concepts. This is a brief outline of what I want to cover. I'm going to talk mostly about soft tissue sarcomas, which is predominantly what we see in adults. Talk about the concept of adjuvant and or neoadjuvant chemotherapy, meaning we'll talk more about what that means. And then also talk about some of the treatment of metastatic disease. Dr. Ogilvy pointed out, those are kind of sort of break it down into two different groupings that way. And then I will touch very briefly on some of the pediatric sarcomas. They're treated differently. And I think it's important for you guys to know that there's some distinctions. Dr. Hurley showed you this slide, but I like it too. This is some of the more common soft tissue sarcoma subtypes. Depending on what classification you look at, there's 50 or 70 or 100 different types of sarcoma, but so at least 50. And one important concept here is that we put these all together in the category of soft tissue sarcoma, and historically a lot of the treatment has been of that group of tumors as a whole, but we're learning more and more over time that these are different diseases in some cases, different behaviors and different responses to treatment. Another thing to keep in mind, surgeons like Dr. Ogilvy, and at our place too, the orthopedic oncologists are sort of the captains of our ship, because most of these tumors arise in the extremities or the limb girdles. Some can arise in the head and neck, and then some can arise in the retroperitoneum or the deep abdomen. In terms of treatment, I think Dr. Ogilvy also pointed out that really if someone has localized disease and we're treating with curative intent, that getting a complete resection is really the key. And so then these other treatments, radiation therapy and chemotherapy, are really adjunctive or adjuvant therapies. The term neoadjuvant means that you're doing this adjunctive therapy prior to surgery. And as we think about the adjuvant or neoadjuvant chemotherapy, we're still kind of using, and our standard treatment algorithms are based on traditional cytotoxic chemotherapies, and these are drugs that they affect rapidly dividing cells most prominently, and they affect or disrupt various aspects of DNA formation, RNA formation, or protein formation. Maybe they affect cell division, but they can be tend to be cell cycle dependent, and really affecting the rapidly dividing cells. And so again, we're talking about adjuvant, neoadjuvant treatment. Sometimes we use chemotherapy also in the setting of metastatic recurrence. And I think it is important to be clear about the intent, because the chemotherapy regimens that we use for neoadjuvant therapy are really pretty aggressive treatment. A lot of toxicity can be associated, including some late or lasting toxicity. And so, you're trying to cure somebody or really achieve long-term survival, increase the odds of that, taking on some risk may be worth it, but maybe it's less worth it in the case where you're not going to cure the disease. That's a very individualized discussion almost every time. I'll try to put this in the context of a case to at least illustrate how I think through these things when we sit in tumor board. So this case will be a 32-year-old male who presents with swelling of his left thigh for a couple months. Initially thought he pulled a muscle working out, but it just didn't get better. And then, he decided to go see his primary care physician, who first ordered an ultrasound, cost-effective imaging, showed a mass, didn't show a whole lot of other detail. So we went out to order an MRI and showed a peripherally enhancing mass with central necrosis in the thigh muscles. Here's a picture like that. So then the patient then gets referred into a sarcoma program, ideally, rather than, as was just discussed, someone could have cut into that and said, hey, let's try and remove that, but that would have been a bad idea. So get referred in, get a biopsy first. In our institution, actually, we do a lot of imaging guided biopsies, and Dr. Ogilvy mentioned doing them in the clinic, but do under image guidance, we can do it either way. The pathologist starts to look at it and sees a high-grade malignancy with some spindled and some epithelioid shaped appearing cells. The immunohistochemical markers are listed there, Vimentin positive, CD99 positive. And then they went on ahead and did some molecular level testing, and in this case used FISH and identified an SS18 translocation. So that's diagnostic of a synovial sarcoma. It's a type of soft tissue sarcoma, does not arise from synovium. So this is one of the ones that's misnamed maybe. And I tend to see it in young adults frequently. after the diagnosis was made, went ahead and got a chest CT for staging, did not identify any metastatic disease in the lungs, which is the most common site for metastases. So then we're thinking, okay, we have this apparently localized sarcoma, young guy, we could treat this with curative intent. And another thing that we do early on is sort of wrap our minds around what is this patient's risk for a poor outcome, for recurrence, or for death from his sarcoma. And for a while now, we've had this nomogram kind of based on retrospective analysis of the large database at Sloan Kettering. And you can calculate or estimate anyway what the risk of dying from the sarcoma would be. And you can see that it incorporates some of the important features here are size of tumor, whether it's low grade or high grade. You can see those bottom bars are really different depending on the grade. And those are really some of the key features about prognosis from sarcoma. Histology can have a significant impact on prognosis as well. A more recent iteration of this kind of thing is a thing called Sarculator, which you can download this app for free onto your phone if you want. And this is an Italian researcher took, again, retrospective data from several large institutional databases, and I think at least one or two multi-institutional data sets to, you kind of take all that data, you pull it, and then you can go back and retrospectively use it to sort of estimate what outcomes might be. For our patient, if you put in his features into Sarculator for a primary extremity soft tissue sarcoma, you see that the predicted 10-year overall survival is just 45%. This is kind of a high-risk tumor. His risk of distant metastasis at 10 years is 62%. So we're starting to get the picture that this thing has some risk associated with it. Essentially, it's a T3 tumor. We don't have evidence of lymph node or distant metastatic disease, high grade. From the two different prognostic tools we have, you can see this risk of distant metastasis and death is pretty high. So what are we thinking about for treatment? I would say in our there's a medical oncology talk. So in our program, we would be thinking about chemotherapy for a case like this, based largely on the risk, but also on the knowledge that the synovial sarcomas tend to be one of your more chemotherapy responsive soft tissue sarcomas. So if we think about adjuvant or neoadjuvant chemotherapy, the goal is to eliminate micrometastatic disease. We know statistically that with a tumor like this, a good percentage of patients at the time they're diagnosed already have little cancer cells out there that have circulated and started to land somewhere, and you can't see them on scans, but we know from the data that they're there. And so the goal is to try and kill off those cells, or as many of those cells as we can, to increase survival and potentially increase the rate of cure. Cure being kind of a hazy term, but it may be analogous to long-term survival, or just hopefully the tumor never comes back. An additional goal with neoadjuvant or preoperative chemotherapy would be to, if you could get any shrinkage of the tumor before surgery, it might be helpful. And I think Dr. Obi pointed out with soft tissue sarcomas, it's not all that frequent that we see a ton of downsizing, but sometimes we do, and our surgeons tell us it's nice. The other thing we know about adjuvant or neoadjuvant chemotherapy is that, I've been doing this job for 15 years, and for a lot of that time, the use of this has been, maybe controversial or not necessarily uniform, some different thoughts about it. And I think that's because we've had mixed study results over the decades, hampered by small studies with heterogeneous populations and different treatment plans and all these things. Hard to make sense of really what the right answer is in terms of using chemotherapy. Dr. Hurley contrasted sarcoma with breast cancer, and I think it's an interesting contrast. Partly, there's maybe 15,000 sarcomas in the U.S. in a year, as compared to like 230,000 some breast cancers, and so getting really good clinical trials done effectively for sarcoma has been harder. It's heterogeneous, it's rare, so that you'll kind of see that in the data. The next 2 or 3 slides is probably getting a little bit down in the weeds for this talk, but I included these slides anyway, just to sort of illustrate how the thinking about this goes over time. So one of the first, so I'll trace out some of the history of some of the data we have. And you can see this first publication was from 1997. And it was a meta-analysis. They took together data from a number of clinical trials that compared chemotherapy to not chemotherapy in people with sarcoma. Again, meta-analysis data isn't the best because it's not, it's not necessarily uniform populations. It's not uniform treatments. The treatments were based on adriamycin or doxorubicin, which, for decades now has been sort of a mainstay for sarcoma. Chemotherapy, it seems to be one of the most active drugs. But in this first meta-analysis, there was really no overall survival benefit in total for the sarcoma patients with chemotherapy. Maybe some increase in recurrence-free survival, but really no overall survival benefit. They did subgroup analysis of extremity sarcomas, and there was kind of a borderline significant decrease in the risk of death, but kind of hard to know what to make of that. Really the first sort of well done randomized clinical trial comparing chemo, sort of optimal chemo to no chemo in a selected high-risk group of extremity of sarcomas was this Italian study, relatively small study though, 100 patients. They ended up, even with long-term follow-up, there was an overall survival advantage, it appeared, but it was kind of weird because the distant relapse rate matched up after several years of follow-up. Next piece of data, another meta-analysis done, published 2008. They added 4 more studies, and all of these had ifosfamide given along with the doxorubicin. And here we started to see actually more significant benefit, but the criticism would still be that this is still a meta-analysis. It's not a randomized trial. We're starting to see that the absolute risk reduction estimate here was taking the risk of death from 46% down to 40%. So not guaranteeing a cure for all the patients by any means, but maybe shifting the needle a little bit. And that's, even in the current day, that's still sort of how we think about the chemotherapy, is you're trying to make sense of some odds that are out there and talk to a patient about that so they can make an informed decision with you about what they want to do. Criticism of this would be that there was the largest randomized controlled trial was not included in this meta-analysis. It was published a few years later. And that's that EORTC study, this next. So here's a really large study, 351 patients, randomized to 5 cycles of adriamycin ifosfamide versus no chemotherapy, and at 5-year overall survival estimate, dead even. So you look at this and say, man, no benefit to chemotherapy. There's a few criticisms of this that we could make, and I'm probably getting in the weeds too much. But so you've got mixed data here. You've got meta-analysis, yeah, there's benefit. Big randomized trial, no benefit. Clinically, we still worry about the people that have the highest risk tumors, large, high grade, and the people that have, chemosensitive tumors. Is there an opportunity to help them with chemotherapy? And in this EORTC study, it's really not accounted for. They included a fair amount of intermediate grade sarcoma. Another criticism, the ifosfamide dosing wasn't really all that high. So there's a few criticisms here, still kind of a murky thing. And then the next slide is a few more modern studies. And we'll go to the bottom one first. This is a retrospective analysis of that negative study, which again, this is not ideal data. But interestingly, they found that people in that EORTC study who really had the highest risk, those with predicted overall survival on the circulator tool, among those people, there was a significant benefit to chemotherapy in terms of overall survival, even though they weren't getting the higher dose ifosfamide. So that gives a little support to the chemotherapy argument. The study above that was an interesting study. In this one, they chose patients with high risk extremity and trunk soft tissue sarcomas, so large high-grade tumors, and they picked 5 subtypes that either generally are or can be chemotherapy responsive, and for each subtype randomized them to either standard epirubicin, which is like doxorubicin, and ifosfamide, kind of the standard chemotherapy, versus a chemo that is supposed to work better for that specific type of sarcoma. So, and what they found was that overall the epirubicin ifosfamide standard chemo is significantly better at lowering the risk of death than the other chemotherapy. So, here it's a randomized study. It's not compared to placebo, but compared to an active comparator in high-risk sarcomas, the standard chemo seems to be better. So I think there's my personal view is there's increasing evidence that neoadjuvant chemotherapy is a good idea to consider for the right patients, people with high-risk tumors that are chemosensitive and who are young and healthy enough to handle it. So I got way too down in the weeds there, and I apologize, but that's sort of how thinking gets shaped about chemotherapy in general, in all honesty. So back to our case, patient did get neoadjuvant chemotherapy. They got preoperative radiation therapy. They had surgery. It all went really well. Kind of shift gears into surveillance and into survivorship phase. Surveillance being scans every, so often at our institution every 4 months for the first couple of years, and then space them out after that. Scanning the lungs with a CT to look for metastatic disease, and scanning the primary tumor site. Unfortunately, about a year in, we have a chest CT, and you can see down here in the right posterior lung, there's a mass that does not belong there. It wasn't on the previous CT scan. Kind of a soul crushing thing. We got to biopsy that and confirm that it's metastatic synovial sarcoma. Well, now we're thinking, what do we do about that? And in the metastatic disease setting, we're not so much thinking about curing the cancer. We know from experience that becomes quite unlikely. I wouldn't say 0% likely, but pretty unlikely in the metastatic disease setting with soft tissue sarcomas. So the goals are really to extend survival and maybe palliate symptoms are some of the goals that we're thinking about. As you're looking at data about chemotherapy in this setting, terms you see are things like response rate. And there's specific definitions of what a response is for clinical trials, but it means it's the proportion of patients in a trial whose tumor is significantly reduced by a treatment. That's just tumor size shrinking or not shrinking. And people's tumors can stay stable in size, not shrink, and as long as they're not growing, that's a good thing. And that kind of gets at the next one. What is progression-free survival? So a progression-free survival rate is a percent of people whose tumors don't grow or who do not develop new tumors sometime during or after treatment. It's often expressed as a median progression-free survival in a clinical trial. Like, what's the average time that people weren't developing any tumor worsening? And overall survival obviously is the time that people are still alive after starting a treatment. As we're thinking about sarcomas, there's all these different types. There's some generalizations that we tend to make, which are they're generalizations. They're not 100% true, but Dr. Ogilvie pointed out, you can see really good responses with a round cell liposarcoma, or with sometimes an angiosarcoma and a Ewing sarcoma. You can see really good tumor regression. There are some types that I've not seen respond to chemotherapy, like extraskeletal myxoid chondrosarcomas, and conventional chondrosarcomas don't respond that well generally. And some of these in the middle where you can see some people respond well, but fair amount of them don't. So those kind of stick in the head of an oncologist as we're thinking about these cases. This slide is a bunch of the kind of older, kind of standard cytotoxic chemotherapies that get used for sarcomas. I'm not going to read the whole slide, but you can see, response rates of 10 to 25%, 10%, less than 10%, 4 to 18%. So there's a large majority of these that aren't dramatically shrinking with chemotherapy. You can see a 40+% clinical benefit rate on one trial with gemcitabine. So that's stable disease plus shrinkage for a period of 6 months. There's room for improvement, and there's some treatment benefit left to be desired here with soft tissue sarcomas, I would say. Sometimes chemotherapy combinations get considered metastatic disease, and questions have been studied like, well, is it worth it giving a really aggressive combination compared to a single drug? It may not be. You can see that there's not a significant difference in overall survival with the aggressive combo treatment. So I'm not going to belabor that point. And then there's another slide here that it was titled Recent Options for Metastatic Soft Tissue Sarcoma, but it's really not that recent because it dates back 10 years ago. But these are the drugs, I guess, in the past 10 years that have been approved by the FDA for treatment of sarcoma in the US. It's 4 drugs, which is not a lot compared to some other diseases. And you can see as we get down to the tazemetostat, that is approved for one specific, relatively uncommon subtype of soft tissue sarcoma, because that's really the place where they found reasonable activity. Eribulin is a drug borrowed from breast cancer. It's approved for liposarcoma. Did improve overall survival compared to an older drug called dacarbazine. So that's kind of where we are. The pazopanib is not a traditional cytotoxic chemotherapy. It's one of these anti-VEGF agents that Dr. Hurley mentioned. So these are ones that are approved. There's a bunch of other drugs out there that are either being studied in clinical trials or has some off-label data in smaller clinical trials for them, but these are what's FDA approved. And then kind of coming up to modern time and where our hopes for some of our hopes for the future lie is in immunotherapy. There's it was pointed out that none of these are approved for sarcoma. There has been some study and we can't find uniform benefit with them in soft tissue sarcomas, but certain subtypes like the UPS, the undifferentiated pleomorphic sarcoma, single agent PD-1 inhibitor was associated with a 23% response rate in one trial. Probably the newer generation of studies is really looking at what do you combine with an immune checkpoint inhibitor to make even more response or get a broader range of tumors to respond. So here you see traditional doxorubicin combined with pembrolizumab, and compared to chemo alone, a relatively good PFS and relatively good objective response rate. So then there's a whole plethora of studies like that going on, different combinations, and not just chemo, radiation therapy combined with checkpoint inhibitors or anti-tumor vaccines, all these things, just kind of the Wild West at this point. Another part of immunotherapy that's exciting is you hear about CAR T cells for some of the blood cancers. There's similar technology modifying the T cell receptor on a patient's own T cells, and then reinfusing them to target these antigens, NY-ESO or MAGE-A4. And there have been some really exciting response rates with those, but this is limited to people whose tumors express those antigens, and it's, SS is synovial sarcoma and MRCL is myxoid liposarcoma. And you have to have a specific HLA type to have this study apply to you. So probably some of our advances we're seeing now are just real specific niches, but there's work ongoing and there's hope that things are going to continue to get better. Jumping onto the pediatric sarcomas, and I actually don't know what time it is, and if I'm over, someone can tell me to hush. I just want to touch on them briefly. I don't think pediatric sarcomas is actually an official designation, but in my mind, I think of them that way because each of these types we see more commonly in either kids or adolescents. And each of these is kind of different from the other adult type soft tissue sarcomas in that the chemotherapy is actually really important and pretty standard in the treatment. And there tend to be some of these well-studied treatment protocols have been developed. The children's cooperative groups over the years have done really nice jobs running big clinical trials that answer important questions and help kind of change and set the course of treatment. So rhabdomyosarcoma, rhabdo means rhabdomyoskeletal muscle. Mostly in kids, you can see them in adults. Again, the progenitor cell is a skeletal muscle cell, you can see them all over the body, but tend to see more in the head, neck, and GU regions than you do the other soft tissue sarcomas. Combined modality therapy with chemotherapy and radiation therapy is standard. And they've actually gotten to where they can really risk stratify patients and do this risk adapted therapy where people with really favorable risk disease can get less intensive chemotherapy than the prior standard. And pretty high cure rate when you give people the standard multidisciplinary treatment. Osteosarcomas, so one of the bone sarcomas would include osteosarcoma, chondrosarcoma, Ewing's sarcoma. The peaks, it's kind of this has two peaks of incidence, one in the kind of adolescent young adult age, and then again in the people in their 60s or so. Don't use radiation therapy as much in osteosarcomas, but chemotherapy, again, really important in the years before people got chemotherapy for this. They were just getting surgery. Less than 20% would have any kind of long-term disease-free survival, and now the cure rates are up 70% or more. And it's even true that people who have limited pulmonary metastatic disease, you treat them with the right, the aggressive kind of state-of-the-art chemotherapy and surgeries and all that, you can get long-term survival or cure in a fair percent of those cases. And Ewing sarcoma was mentioned a few times. It's another one very chemosensitive, and the standard protocols include multi-agent, pretty aggressive chemotherapy and either surgery or radiation, typically for local control of the primary tumor. And again, pretty good cure rates. Any more with that? So in summary, I'd say for adult patients with your soft tissue sarcomas, in terms of chemotherapy in the curative disease setting is selected patients. I think there's a role for it, and it's, there's some pros and cons to weigh through with that. In metastatic disease, there's some role for chemotherapy. You got to carefully balance risk and benefit, and look for clinical trials, look for some newer things to expand the options for patients in that setting, I think is a good idea. And then the pediatric sarcomas, there, different chemo is central to curing those tumors. So I'll stop. I think that's my last slide. I'll stop. Anybody has questions, please shout them out. Or I know Dr. Akuno is on the line, and he can clarify any things I didn't say very well, or argue with my perspective on other things. So
I thought that was really great. Very nice. Thank you.
yeah, you're welcome.
Anybody have anything to add? Questions? Everybody's quiet.
I talk too much, I think. And hopefully Scott didn't drive into a ditch hearing me say that I give chemotherapy in the neoadjuvant setting. I don't know.
No, I
You guys, how are you guys? Some places are big chemo proponents and some are less so. What do you guys do at Minnesota?
Well, Dr. Skubitz is not here to defend himself. He, in general, has been late to the party of wanting to give chemotherapy. He's been very slow to recommend it, but recently it's more. He's been, and then we have a new faculty member who is here today for the first time. What do you think?
Yes.
This is Andrea Espejo Freire. How do you say her last name?
Yeah, Espejo Freire.
She just joined our faculty 2 weeks ago.
Oh, that's pretty cool. Good.
From Miami.
Miami, so yeah, I trained University of Miami in Sylvester, and so I come from a background where they are very aggressive, and the person that I'm training, he came from India, Anderson, and they do a lot of high doses of chemo. And so here in area where in constant meetings with Dr. Skubitz to come back with but yeah, it's a case to case basis. Your talk was really useful in the sense that sarcomas are very, very complex tumors, and the decision of doing 1 versus 2, it depends on the patient, it depends on the symptoms. So it's not one size fits all. But and it also stresses the importance of treating these tumors in a specialized center. That's the first thing. See sarcoma sent to some place that they are actually seeing these cases on a daily basis.
I have had instances where someone, I don't know, they make their way to us, not initially, but later, and they've been told by their oncologist, chemo never works for a sarcoma, don't ever bother. And I was like, well, it's not universally true. So anyway, and so I think the treatment actually has changed maybe over the past 10 to 20 years. We're finding a little more about how to treat these more successfully, and it's too slow, but we're making progress.
Yeah, very good.
All right,
Okay,
thanks.
thank you. Last but not least is radiation oncology. And I'm happy to be presenting today, but I see Sarah Alcorn, our new faculty member, is on also. Sarah, feel free to jump in and correct me on any, or add any point you wish. I'm Katie Dusenberry, and I am really happy to be here. Let me just, I'm going to talk about the role of radiation therapy in soft tissue sarcomas. I think you've already gotten the message. We think bone sarcomas or chondrosarcomas are pretty radio resistant. We sometimes get asked to do it, but in general, it's a chemotherapy and surgery disease. So I'm not going to talk about that at all today. I'm just going to talk about the soft tissue sarcomas. And as Dr. Ogilvie pointed out, surgery is the mainstay of even soft tissue sarcomas, and radiation is adjuvant. You've heard the word adjuvant many times tonight. Adjuvant means enhances the effectiveness of the medical treatment, the main treatment. So radiation isn't, we sometimes get asked to treat definitively a soft tissue sarcoma for crazy reasons usually. And we have to go to really high doses, and it isn't very often completely successful. So the best use of radiation is in the adjuvant setting. Soft tissue sarcomas tend to start in muscles or tendons or any mesenchymal area, but they kind of spread in the path of least resistance up and down the muscle, and only late do they go through fascial planes, and they push against vessels before they invade into vessels. And there's a little pseudocapsule around it, but that pseudocapsule is misleading because there's the sarcoma, and then they tend to have these little satellite lesions. So if all you take out is the little tumor with the pseudo, without some tissue around it, you're going to leave the little satellite guys behind, and you're going to get a local recurrence. So historically, surgery was the mainstay. And often when I started practicing, which was now really a long time ago, surgeons would do these big radical resections. They'd get the tumor out, and sometimes like the whole muscle compartment, or really try to get big margins around it. Luckily, we don't do that anymore, but it used to even be not that uncommon that there would be a lot of disability after a big sarcoma surgery, sometimes even amputations. We don't do those as much anymore, or I never did one, but the surgeons don't do them as much anymore. But the principles of the surgery is there's a radical resection where you take the whole muscle bundle. There is a wide resection where you take the tumor plus a plane around it. And a marginal would be just the tumor with a little rim, and intralesional is a no-no because they always recur. So way back when I started practicing, the NIH did this randomized trial, because up until then, surgery was the mainstay, and that surgery was either a radical or an amputation, and they did this randomized study, and the numbers just kind of move formatting here, but they randomized people between radical surgery and the less radical surgery, just a marginal limb sparing surgery with radiation afterwards. And lo and behold, the local recurrence rate was a little higher. Got an amputation, you can't have a local recurrence rate. But if you have radiation, you can. It was a little bit higher in the radiation arm, but the disease-free survival and the 5-year survival were the same. So since that time, we've known that you can do less surgery with radiation. I'm sorry that formula is bad. Since that time, there's been tons of studies showing that you can do less of a surgery, limb-sparing surgery, and add radiation, and you have excellent local control. So that's really the standard today. But when do you do the radiation adjuvant? Do you do it before surgery? Do you do it after surgery? You can actually even do it during surgery. You take out the tumor and put little ribbons in the tumor, put radiation in, either temporarily or always temporarily, but you can do it, close up the wound and give some radiation and then pull out the catheters a couple days later. It's only frequently done and only in large centers, and really it isn't widely available. And you can do a combination. So in our world, this O'Sullivan trial was done. It's a big Canadian trial where the original NIH study that we talked about was all post-op radiation, but there's some theoretical advantages to thinking about doing the radiation beforehand. Chris already talked about that. It's really easier to radiate something you can see. If you got a lump there, it's easier to put a field on it to make sure you're treating the lump and with a little margin. Unlike post-op where you have this big scar and a big tumor bed, and theoretically anything in that area could gotten contaminated, so you have to treat a bigger area. So if you treat pre-op, current thinking is that you can give less of a dose, 50 gray. If you treat post-op, the thinking is that the tissue is less vascularized and you need oxygen getting to the tissue for the radiation to be as effective. So you have to give a bigger dose. So you give a bigger field. So pre-op, smaller dose, smaller field, something to aim at. Post-op, bigger field, bigger dose. Sullivan did this really nice Canadian National Cancer Institute randomized trial where they randomized the people to 2 different arms. And lo and behold, the cure rate's the same. And with long follow-up, the long-term side effects are much less for the people that got pre-op, less joint dysfunction, less fibrosis, not surprising. Cost of that, though, is wound complications, because about a third of patients who get pre-op radiation will have some wound complications, but those almost always heal. Sometimes you need those wound vacs that Dr. O'Leary was talking about, or you have to be on antibiotics, or there's some delay. But in the long term, because there's less long-term morbidity, we as radiation oncologists prefer the pre-op if we have our druthers. COVID epidemic has done a few good things, and one of the good things it's done is, made us think about that 5 weeks of pre-op radiation. Maybe we could put that down to 5 days. We've been really, so patients come and see me and they say, you're not going to do surgery for, down the road. You see me, I'm going to do the simulation, I'm going to do the planning, I get 5 weeks of radiation, then you're going to wait 5-6 weeks to do surgery. No, I don't like that. You have to talk them into that works better. Our survival's the same. Don't worry about it. Other tumors have gone away from long course pre-op radiation for a variety of reasons. Breast cancer we can do now in 5 days. Lots of data that's just as good as what we used to do 7 weeks for breast. Rectal cancer, really good data. 5 days is as good as the 5-week course. COVID has put the pressure on the medical system in a lot of ways. So there's been 2 small trials, one in elderly patients and one in, I think, all comers, but only about 16 patients, where they decreased the dose to 5, or decreased the time to 5 fractions, about 600 centigrade a day instead of our usual 200 a day. So it's each day you get a bigger dose. And preliminarily, the local control is exactly the same, and the wound complication is about the same too. If it was lower, we'd be really happy. But, so I'm thinking that's the way of the future. It hasn't been tested out yet. I'd actually like to do a trial here with trying to see if we can make the wound complication less and treatment over 5 days. If anybody has any good ideas what we could do, I'm all ears. So I want to briefly introduce you all to radiation. You don't need to know all of this, but my near and dear to me. So we see a patient for a consult and decide, for whatever reason, we decided they need radiation. So we do what's called a simulation, where we put them in a position on the treatment table where we know there'll be reproducible day to day, because you got to aim at the same spot each day. And we put marks on the skin. Some people get tattoos. If you don't want a tattoo, you don't have to have a tattoo. We put them in molds or immobilization devices so that each day we can get to them into the same position. This is an old one. We used to make these things where we put chemicals in a garbage bag and it would puff up, and you put it under their leg and it would get firm and we immobilize them that way. We don't do that anymore. I like this slide. And then we do a CAT scan with them in that position and draw, and you can see the tumor. And as a radiation oncologist, you draw all the anatomy of what you want to treat and what you don't want to treat. We call that contouring, and you draw the tumor and then you expand it and put a margin around it for where these little satellite cells might be. And we have language for that. We call the tumor itself the GTV, the gross tumor volume. And then we put a margin around it, and we have guidelines that are well established of how much margin you put. radially, because it doesn't spread radially as much, or up and down a different margin. And then we call that the CTV, the clinical treatment volume, where there might be microscopic cells. Yeah.
We just got a text that they're not seeing the slides advance.
Oh, at all from the beginning?
I don't know, can we check with everyone and make sure, at least that was from one person?
Yeah, from Madison.
I'm going to share again, maybe. Did everybody see?
That looks like the right slide.
Okay, were you seeing them, Sarah?
No, but I thought it might have just been on my end. I'm sorry, but now I see the CTV PTV slide there.
My really great slides. Oh, okay. Do I go back or do I just stay from here? Probably just from here.
Yeah.
Yeah, I think so too. Okay. Now I can't do things. That's interesting.
Try the wheel on the mouse.
Okay, that's going too good, but okay. Okay, so then once you've got the tumor drawn, we have people called dosimetrists who will take your tumor and then they'll put, kind of by trial and error, some beams on. And their job is to make the tumor get the full dose and the surrounding tissue as much as possible. And there's a variety of ways we can do that. It's not, it's into the weeds, as Dr. Charlton said, to how we do that. But we come up with some plans, and your dosimetrist will show it to you. You pick which one you like, but sometimes they'll show you a bunch of different targets and or plans. It's hard to tell which one's the best. So one of the ways we analyze them, here's a more complicated one with a bunch of beams going through it. And we have even, this is not that, this is kind of old. We have even fancier arc therapy and whatnot. But we do what's called a dose volume histogram, where on the left side here says the volume, that's the target of whatever you're thinking of, the volume of whatever organ. And then the bottom is the dose. And for pre-op radiation, we want to get 5,000 rads. So you can see that the tumor is getting 5,000 beautifully, and everything else is getting less. So for instance, in purple here is the left femur. And you can see that half of the femur, 50% of the femur, is getting less than 500 centigrade. That's a nice play. But the more everything is over to the left, normal tissue is getting nothing. And the more your target is getting 100%, the better the plan is. You can compare different plans and you decide which one you like. The wheel. And then you bring the patient in and you treat them and you lay them on the table and you get them, their skin looks like they're in the right place. But you can't just turn those beams on any way. You got to make sure they're really where they're supposed to be. So you do a image guidance where you'll do there's a CAT scan on our linear accelerator. We'll do a quick CAT scan called a cone beam. And you fuse the planning CAT scan where you drew all the targets to the cone beam one on the machine. And then you can checkerboard here and you make sure that whatever you're interested in lines up. This happens to be a prostate cancer patient, or something. Rectum. You're lining, but you can line up bones. You can put gold seeds in the tumor and line up the gold seeds, but that's called image guidance. So we routinely use image guidance for our sarcomas too. So what's the workflow for a typical sarcoma patient? They will present with a lump, and hopefully they'll get a biopsy by a good person, good orthopedic surgeon who knows what they're doing, proves it's sarcoma. Then they usually order the PET scan. Or treatment plan or a CAT scan. They almost all, I've heard this spread to lungs, that's where they usually go, but we like PET scans because there's some tricky ones that spread to lymph nodes, and there's a mnemonic to remember which ones spread to lymph nodes. It's called SCARE or RACES, and it's certain subtypes that have a slightly higher risk of spreading to nodes. If you're really interested, I have a slide I can show you for that. But anyway, you get the PET scan and then you give them a stage, and there's a T, N, and M stage. And then we have this multi-D clinic where we sit around, and you're all welcome to come to ours at 7 o'clock on Thursdays. Mayo has one a different time, and I'm sure Medical College of Wisconsin and University of Wisconsin have one, where we have pathologists, radiologists, surgeons, medical oncologists, medical students, residents. We present the cases and we just kind of talk about what we think the best algorithm for treatment is going to be. Look at the past slides and come up with a plan. Some of them, sometimes now we're getting pre-op chemotherapy for large high-grade tumors, more and more. But then usually we advocate for pre-op radiation, and that's 25 treatments over 5 weeks, but might go down to 5 treatments. We usually wait 4 or 6 weeks, and then they have surgery. And then once they have surgery, they cover that wound healed, and then they're on surveillance mode where you get a chest CT. We do them, I think, every 3 months to 4 months for 2 years, and then every 6 months for 3 years. Get a baseline post everything MRI because want to follow the local recurrence as well. A lot of possible long-term side effects, much less for only the 5-week course than the 6 or 7-week course. Fibrosis, lymphedema can happen, especially if you circumferentially radiate an extremity. They are prone to osteoporosis or osteopenia, especially if you circumferentially irradiate the femur or the humerus, so you try not to. Secondary malignancies, unfortunately, do happen. Nerves can take about 60 gray, so go pre-op, less neuropathy too. So when can radiation be omitted? Well, probably surgery alone is okay for a superficial tumor, a low-grade tumor, and a small tumor. And but that's not all. Sometimes a little bigger tumors we radiate alone, especially if they're easy to follow. But we almost always advocate for adjuvant radiation for a deep tumor like this one at the bottom. A larger tumor, 5 centimeters is kind of cut off. And if it's high grade. You already saw this Memorial Sloan Kettering algorithm for survival. Well, they also have it for local recurrence. So what's the recurrence after limb sparing surgery if you don't give radiation? And you can put in your numbers, for instance, a 61-year-old guy with a 3 centimeter tumor with a close margin, it's high grade, what's the risk? And then you put in the histology, because what's the risk of a local recurrence? So you can help you decide what to do based on this. There are a couple tumors where surgery is not what you do. And this is one of the ones you don't like to see. It's a little girl that had an orbital rhabdomyosarcoma. The treatment for that surgically would be remove the eye. And luckily, rhabdomyosarcoma is one of the really chemosensitive ones. And it's very sensitive to radiation too. So this patient gets chemotherapy, and usually it shrinks down and you give radiation. It's a pretty modest dose of radiation, somewhere between 45 and 50 gray. It's not nothing, but they have excellent, it's one of the really good prognosis for rhabdomyosarcoma. Yeah.
Alveolar rhabdomyosarcoma versus rhabdo
This is orbit. It's orbit means in the orbit.
Yeah.
And it's they're so the histology of rhabdomyosarcomas, there's 2 main subtypes. One is alveolar and one is embryonal. And that's not to be confused with orbital. Orbital is usually one of the good ones. I think they're usually embryonal. Is that right, Sarah?
Yes.
It's one of the good ones. That's my presentation, and I'll show you just for fun. These are the ones that spread by lymph nodes: race, rhabdo, angio, clear, and epithelioid. And I think it's also called SCARE, synovial, clear cell, angio, rhabdo. You know, medical students, you like mnemonics, right? They're good for tests. Anyway, that's my presentation. Any questions about radiation? Anything to add, Sarah?
No, I think that was a very good review.
Thanks. Anybody else have any questions about anything?
How much more complicated is tabular responding to radiation versus temporal or orbital?
So ask that again. Take off your mask and ask it.
But because we've had such a big family workup with alveolar rhabdomyosarcoma.
So alveolar rhabdo is usually
Thank you.
of the, it's called alveolar because under the microscope, to the pathologists, they've always made it crazy. They look like lung. It doesn't have anything to do with lung. It's a subtype of rhabdo. It's worse, and it's usually on the extremities. Something, it can be anywhere, but it's a worse type of rhabdomyosarcoma. Is that your question?
But it doesn't respond as well. And thank you for telling me how to pronounce it correctly. Because it's like, oh God.
Alveolar, yeah. Mhm.
But it doesn't respond as well to radiation.
So it's usually in the legs or extremity, and therefore you can do surgery. And so you don't want to do radiation in pediatric patients, you can help it. So they would get chemotherapy. They usually respond very nicely. They get smaller. They see Dr. Ogilvy, and he and I decide he thinks he can remove it with a negative margin. That's what he does. We often, because it's just a worse rhabdo, will give a low dose of radiation with it, just because it's alveolar rhabdo, it's worse.
Yeah. No, thank you. There's a reoccurrence for an adult too that I'll probably have.
And adults that get rhabdo, it's not the same disease as kids that get rhabdo. There's probably more mutations or more, they can't tolerate chemo as well, or if they're the same name, but they're not the same disease. Is that right? Would you say that? Right? Yeah. So another complication. Okay, thanks for your attention. What time is it? It's like 8 o'clock? No, I think so. Yeah, we did good. Well, thanks. It's been recorded. If anybody wants it for posterity, I'll stop the recording. Is that what I do?
Yeah. Hannah had great directions. I just don't know where they went.
I don't know. Oh, here's recording. I just stop it.
Yeah.
Okay. Thank you.
Yeah, thank you guys. Hats off to you scholars. Way to go.
Yep. You know how to find us. Reach out if you have questions.
Yeah, thank you so much for organizing everything. We really appreciate it.
Thanks for your attention. It was rewarding.
Thank you. Thank you. Bye.
Just stop. What do I do?
I don't think you've stopped recording.
No, I know.
yet.
I'm afraid
Press
to.
the square button.
Isn't this over to the right?
So like they're